Welcome to the deep dive. Today we're tackling a topic that you're definitely going to come across, gallstones, or cholelithiasis as it's known.
Absolutely. It's a really common one.
Yeah, and we've basically boiled down a whole load of revision material to just the essentials. Our mission today, to give you a super clear grasp of gallstones, from what they are right through to complications.
And it's worth knowing something like 15% of people in the UK get them at some point.
15%. Wow. Okay, so let's dive right in.
Let's do it. So maybe start with the basics. What actually are gallstones?
Okay, so put simply, they're like solid little lumps. They form inside the gallbladder.
Which sits just under the liver. Yeah, little storage sac for bile.
Exactly. And there are two main types you really need to know. The big one, making up maybe 80% of cases here in the UK, those are cholesterol stones.
Right, cholesterol. That's when cholesterol in the bile sort of crystallizes out.
Yep. And the other main category, pigment stones.
Yeah, yes. Pigment stones.
Yeah.
And these break down a bit further, don't they?
They do. Go on.
Well, you've got black pigment stones first. You tend to see these more in people with conditions like haemolysis, where red blood cells break down too fast, or liver cirrhosis.
Okay. Hemolysis or cirrhosis.
Yeah. And these black stones, they're usually kind of small, a bit crumbly, and interestingly, they often won't show up on a standard X-ray. They're radiolucent.
Right, so X-ray might miss them.
Then you have mixed stones, which, like the name says, are a mix of things: calcium salts, pigment, cholesterol.
A bit of everything.
Pretty much. And here's a key point. About 10% of these mixed stones are radiopaque. You can see them on an X-ray. They often look faceted, too, like little tut gems.
Oh, interesting. So some do show up. Is there another type?
There is, yeah. Brown pigment stones. Much less common over here, less than 5% of cases, probably.
Okay, brown ones.
These are usually linked to bile not flowing properly, stasis, and often infection, typically with bacteria like E. coli or Klebsiella.
Got it. So just to quickly recap, cholesterol is the main player, 80%. Black pigment linked to haemolysis cirrhosis. Mixed can sometimes be seen on X-ray. And the rarer brown ones linked to stasis and infection.
Nicely summarized.
Okay, so that's what they are. But why do they form? What's the actual cause, the etiology?
Good question. For the cholesterol stones, the most common ones, it really boils down to an imbalance in the bile's ingredients.
An imbalance? How so?
Basically, you get too much cholesterol or not enough bile salts. Bile salts normally keep the cholesterol dissolved, acting like a detergent.
Oh.
So if that imbalance is off too much cholesterol or too few bile salts, the cholesterol can start to precipitate out. It forms tiny crystals first.
Like sugar in tea if you add too much.
Exactly that analogy.
Oh.
Can't stay dissolved, so it solidifies, and those crystals clump together and grow into stones over time.
Makes sense. And the pigment stones, is it a similar kind of imbalance?
Sort of, but with a different key ingredient. Pigment stones are mainly about having too much bilirubin in the bile.
Bilirubin.
Yeah.
That's from red blood cell breakdown, right?
Precisely. So if you have conditions where red blood cells are breaking down more than usual, like hemolysis again, or if the liver isn't processing bilirubin properly, like in cirrhosis.
You get excess bilirubin in the bile.
Exactly. And that excess bilirubin can then combine with calcium in the bile, forming these insoluble compounds that then solidify into pigment stones.
Okay, so different pathways. Cholesterol balance versus bilirubin levels. Now, who's most likely to get these? The risk factors.
Yes. This is where that classic mnemonic comes in super handy. The 5 Fs.
The 5 Fs. Everyone remembers that one. Let's break it down. First F.
Fat. This refers to obesity. But interestingly, rapid weight loss is also a risk factor.
Right, both ends of the scale almost. Why is that?
Well, obesity tends to increase the amount of cholesterol the liver pumps into the bile. Rapid weight loss, maybe through very low-calorie diets or bariatric surgery, can also mess with bile composition and gallbladder emptying.
Okay. Fat. Next F.
Female. Women are definitely more prone to gallstones than men. Why is that? Hormones?
Mostly, yeah. Estrogen seems to play a big role. It increases cholesterol secretion and can reduce gallbladder motility. That's why pregnancy and using oral contraceptives are also linked risks.
Which ties into the next F.
Fertile. Often interpreted as multi-parity, having had multiple pregnancies. Again, likely due to those hormonal shifts during pregnancy.
Okay. Fat, female, fertile, fourth F.
40, meaning age over 40. The risk just generally increases as people get older.
Makes sense. And the last F.
Family history. If gallstones run in your family, your own risk is higher. Suggests a genetic element, maybe influencing bile production or gallbladder function.
So the 5 Fs. Fat, female, fertile, 40, family history. A really useful starting point. Are there other risks outside of those?
Oh, definitely. Things like a diet high in fat and cholesterol, maybe low in fiber, can contribute. A sedentary lifestyle doesn't help either.
Right. Lifestyle factors. Yeah. And certain medical conditions, like diabetes, we already mentioned cirrhosis, Crohn's disease can also increase risk. And some medications besides the pill, like certain cholesterol-lowering drugs, actually.
Okay, quite a few things to consider there. So we know the risks. Let's think about the actual process again, the pathophysiology. How do these stones actually form?
So we touched on the imbalance. For cholesterol stones, you start with bile that's supersaturated with cholesterol. Too much cholesterol for the bile salts to handle.
Supersaturated. Okay.
Then nucleation happens. That's the start of crystallization, where tiny cholesterol crystals begin to form. Other factors in the bile, like mucus, can kind of help this process along, acting as a scaffold.
Right. And then they just grow.
Pretty much. Over time, these microcrystals aggregate, stick together, and grow larger, eventually forming those macroscopic stones we can actually see.
Like building a snowball. And the
Yeah.
pigment stones. You said bilirubin and calcium.
Yeah, for pigment stones, it's more about that excess unconjugated bilirubin binding with calcium. This forms calcium bilirubinate, which is insoluble and precipitates out of the bile to form the stones. It's less about supersaturation and more about precipitation of these specific compounds.
Different chemistry. And a really key thing here is that someone can have these stones.
And have absolutely no idea.
Right. Completely asymptomatic.
Yeah, a large percentage of people with gallstones never develop symptoms. The stones just sit there quietly in the gallbladder. It's only when they start to move and cause a blockage, usually in the cystic duct.
The tube leading out of the gallbladder.
Exactly. That's when the trouble usually starts. Obstruction is the trigger for symptoms and complications.
Okay. Which brings us neatly to thinking about differential diagnoses. If someone comes in with that upper abdominal pain, what else needs to be on our list besides just gallstones?
Oh, absolutely crucial. You've got biliary colic itself, which is gallstone-related pain. But then you need to consider acute cholecystitis, this inflammation of the gallbladder, usually due to a persistent blockage.
Okay, inflammation. What else?
Cholelithiasis. That's when a stone has actually moved out of the gallbladder and into the main common bile duct. That can cause similar pain, but often jaundice too.
Stone in the main duct. Got it.
Then there's gallstone pancreatitis if a stone blocks the pancreatic duct. Very serious.
Right, pancreatitis.
And then you have to think broader too. Could it be peptic ulcer disease? Or GORD, gastroesophageal reflux?
Mm-hmm.
Maybe even something like irritable bowel syndrome, though the pain pattern is usually different. Or even cardiac pain sometimes.
Good point. Always keep the differentials broad initially. Okay, let's talk numbers again. Epidemiology. How common is this in the UK?
So, as we said earlier, prevalence is estimated around 10 to 15% of adults. It definitely goes up with age.
Higher in older people?
Yep. And there's that female predominance we mentioned linked to the hormones.
Okay. And what about people who have stones but no symptoms? Do they usually stay asymptomatic?
Not always. Studies suggest about 2 to 4% of asymptomatic adults in Western countries will develop symptoms each year. So over time, a fair few will eventually run into problems.
2 to 4% per year. Okay. And when they do become symptomatic, what's the most common way they present?
The two big ones are biliary colic, that accounts for maybe just over half, say 56% of presentations. And then acute cholecystitis, the inflammation, that's around 36%.
So colic and cholecystitis are the main scenarios we'll see.
By far the most common, yeah.
Right. Let's dig into those clinical features then. What does biliary colic actually feel like? What are the signs?
Okay, biliary colic, it's typically intermittent pain, often severe, usually located in the right upper quadrant, the RUQ, maybe the epigastrium, just below the ribs in the middle.
Intermittent RUQ or epigastric pain.
Yeah. And the classic trigger is often eating a fatty meal, maybe 30 minutes to an hour afterwards.
The fatty meal trigger? Why is that again?
It stimulates the release of cholecystokinin, a hormone that makes the gallbladder contract forcefully to release bile for digestion. If there's a stone near the exit, that contraction pushes the stone against the opening, causing the blockage and pain.
Ah, the gallbladder squeezing against the blockage. Makes sense. What else might patients report with colic?
They might feel bloated, nauseous, maybe even vomit, some indigestion-type symptoms too.
And the pain itself, how's it described?
Usually comes on quite suddenly. Often described as a constant dull ache, but it can be really quite intense, making people restless.
Duration.
Typically lasts more than 30 minutes, but usually resolves within, say, 5 hours. If it lasts longer than that, you start thinking about
Cholecystitis.
exactly acute cholecystitis. That's when the blockage persists and the gallbladder wall gets inflamed.
So what are the signs that it's progressed from simple colic to cholecystitis?
The pain changes. It becomes more constant, usually lasts longer than 5 hours, and it's often more severe. Patients nearly always have a fever.
Fever is key then.
Yep. And on examination, they'll be really tender in the RUQ or epigastrium. You might feel muscle guarding or even rigidity there.
And Murphy's sign.
Ah, yes, Murphy's sign. That's a classic. You press gently under the right ribs and ask the patient to breathe in deeply. If they suddenly catch their breath and stop inhaling because of sharp pain as the inflamed gallbladder hits your fingers, that's a positive Murphy sign.
Got it. A sudden stop on inspiration due to pain. Any other signs with cholecystitis?
They might have rigors, those intense shaking chills indicating significant inflammation or maybe even infection.
Okay, that sounds much more serious. And then even more urgent is ascending cholangitis.
Absolutely.
Yeah.
That's a bacterial infection within the bile ducts, usually because of a blockage by a stone in the common bile duct. It's a potential emergency.
And the classic signs for that?
Remember Charcot's triad. It's RUQ, pain, fever, and jaundice.
Pain, fever, jaundice. Charcot's triad.
If it gets even worse, you might see Reynolds pentad, which adds 2 more signs: hypotension, low blood pressure, and confusion or altered mental state. That indicates severe sepsis.
Okay, Reynolds' pentad is Charcot's plus low BP and confusion. Definitely an emergency.
Definitely. Sepsis pathway immediately.
Are there other complications or ways gallstones can cause trouble?
Yes, quite a few, potentially. We mentioned gallstone pancreatitis stone, blocking the pancreatic duct outlet.
Right.
Gallstonolysis is rare but serious. A large stone erodes through the gallbladder wall into the bowel, travels down, and causes a blockage, usually in the small intestine.
Wow, eroding through the wall.
Yeah. Then there's gallbladder empyema, essentially pus, collecting inside the gallbladder due to severe infection.
Empyema means pus.
Exactly. And long-term inflammation from stones slightly increases the risk of gallbladder cancer, though that's still relatively rare overall.
Okay, cancerous too.
And one more specific one is Moritzi syndrome. That's where a stone impacted in the cystic duct or gallbladder neck actually compresses the main hepatic duct from the outside, causing obstruction and jaundice.
Moritzi syndrome, external compression. And just circling back, you said many are initially asymptomatic?
Yeah, maybe up to 70% initially. But of those, maybe 10–25% will eventually develop symptoms over their lifetime.
Okay, a significant minority becomes symptomatic. Right, so someone presents with these features. How do we investigate? What tests do we order?
Start simple at the bedside. Basic observations, temperature, heart rate, blood pressure. They might be normal in simple colic, but you'll often see tachycardia and fever in cholecystitis or cholangitis and hypotension in severe cholangitis.
Vitals first. Anything else bedside?
Urinalysis is always useful to rule out urinary tract causes, and importantly, a pregnancy test in women of childbearing age.
Good point. Then bloods.
Yep. Full blood count, FBC. Looking for a raised white cell count, suggesting inflammation or infection common in cholecystitis, cholangitis, pancreatitis.
FBC for white cells. What else?
CRP, reactive protein, another marker for inflammation. It'll likely be up in those same conditions.
Okay, CRP.
Then, crucially, liver function tests, LFTs. If there's a blockage in the bile ducts, like in cholelithiasis or cholangitis, you'll often see raised ALP, alkaline phosphatase, and bilirubin. ALT might be raised too.
LFTs for duct blockage.
Yeah, exactly. And if you suspect pancreatitis is involved, you need serum lipase, or amylase. A level more than 3 times the upper limit of normal strongly suggests acute pancreatitis.
Lipase or amylase for pancreatitis. Got it. What about imaging? That seems key.
Absolutely essential. The go-to first test is nearly always an abdominal ultrasound scan, USS.
Ultrasound. What can that show us?
It's great for seeing stones within the gallbladder itself. It can also show signs of cholecystitis, like a thickened gallbladder wall or fluid around the gallbladder. And it can often pick up dilatation, widening of the bile ducts if there's a downstream blockage.
How good is it at finding stones?
Pretty good. Sensitivity is around 90–95%, but it is operator dependent. The skill of the sonographer matters. Sometimes if the picture isn't clear or symptoms persist despite a normal scan, you might need to repeat it or move to other imaging.
Okay. What if ultrasound isn't enough or we suspect complications?
Then you might consider an abdominal CT scan, usually with contrast. CT is good for looking at complications like pancreatitis, It shows the pancreas well, or detecting bile duct dilation in cholangitis, sometimes even abscesses. It's not actually as good as ultrasound for seeing stones in the gallbladder, though.
Interesting. So CT for complications mainly. Any other imaging?
Yes. For specifically looking at the bile ducts in detail, especially if you suspect a stone in the common bile duct but ultrasound wasn't definitive, the best non-invasive test is MRCP,
MRCP.
magnetic resonance cholangiopancreatography. It's an MRI scan optimized to visualize the bile and pancreatic ducts really clearly. No radiation, no contrast usually needed.
Okay. MRCP for detailed duct views.
Yeah. If MRCP is impossible, maybe the patient has a pacemaker or severe claustrophobia, then endoscopic ultrasound, EUS, is another option. An ultrasound probe on the end of an endoscope gets really close views from inside the stomach or duodenum.
EUS as an alternative. And what about ERCP? I hear that mentioned a lot.
Right, ERCP, endoscopic retrograde cholangiopancreatography. This one is different because it's not just diagnostic. It's often therapeutic, too.
Ah, so you can treat things with it.
Exactly. It involves passing an endoscope down to where the bile duct enters the duodenum, dye is injected, and x-rays are taken. That's the cholangiopancreatography part. If stones are seen in the common bile duct, they can often be removed during the same procedure.
So ERCP is more invasive but allows for intervention, like stone removal.
Precisely. It's usually reserved for when you strongly suspect or have confirmed stones in the common bile duct that need removing, or for other interventions like placing stents.
Got it. So quite a diagnostic pathway there. Now, management.
Yeah.
How do we actually treat gallstones once we've found them?
It really depends. Are they causing symptoms? What kind of stones? Are there complications? The approach is tailored.
Okay. What if they're asymptomatic, found by chance on a scan?
Generally, if they're truly asymptomatic, the approach is conservative. Just watch and wait. No active treatment needed unless symptoms develop.
Makes sense. Don't fix what isn't broken. But what if they are causing symptoms, like biliary colic?
For symptomatic stones, or if complications arise, treatment is usually recommended. Simple measures first might include lifestyle advice, particularly a low-fat diet, to try and reduce gallbladder stimulation.
Low-fat diet, does that cure it?
Not usually, but it can reduce the frequency or severity of colic episodes for some people while waiting for definitive treatment. There's also a medication, ursodeoxycholic acid, or UDCA.
UDCA, what does that do?
It can sometimes help dissolve small, pure cholesterol stones over a long period, maybe 6 to 18 months. But it only works for specific types of stones. Needs a functioning gallbladder, and stones often recur when you stop the medication. So its use is quite limited, mainly for people who can't have surgery.
Okay, so UDCA is niche. What's the main treatment then?
The definitive treatment for symptomatic gallstones is usually surgery to remove the gallbladder entirely, cholecystectomy.
Removing the whole gallbladder.
Yes. And the standard way to do that nowadays is laparoscopically keyhole surgery. Laparoscopic cholecystectomy, often called a lap col.
Lap col. That's the gold standard.
Pretty much. Less pain, faster recovery, smaller scars compared to traditional open surgery. It's preferred for most cases of recurrent colic or uncomplicated cholecystitis.
Okay. What about the more urgent situations, like acute cholecystitis or ascending cholangitis?
Right, emergencies need prompt action. For ascending cholangitis, it's critical. Manage it like sepsis. The Sepsis 6 bundle within the first hour is key. Oxygen, fluids, IV antibiotics, take blood cultures, monitor urine output, check lactate.
Sepsis 6, and then deal with the blockage.
Yes, urgent biliary decompression is needed, usually achieved via ERCP. During the ERCP, they might perform a sphincterotomy.
Cutting the muscle at the end of the bile duct?
Yeah, widening the opening. Then they can extract stones using baskets or balloons, maybe use lithotripsy to break up big stones first. Sometimes a stent is placed across the blockage to ensure drainage.
ERCP for drainage and stone removal in cholangitis.
That's the usual approach. If ERCP fails or isn't possible, surgical options like laparoscopic common bile duct exploration might be needed. For acute cholecystitis, it's usually IV antibiotics, pain relief, fluids, and then typically arranging for a cholecystectomy, often within the same hospital admission or soon after recovery.
So lap col is still the goal for cholecystitis too?
Generally, yes. Timing can vary. Sometimes it's done early, within a few days, sometimes delayed a few weeks.
Okay. What about stones specifically in the common bile duct, choledocholithiasis?
Multiple options there. You could do a lap col combined with laparoscopic exploration of the common bile duct to remove the stone simultaneously, or do the lap col first and then tackle duct stones later with ERCP and sphincterotomy extraction. Or sometimes, if stones are irretrievable, a long-term stent might be placed via ERCP. Complex cases often need a multidisciplinary approach.
Lots of options for duck stones. What about gallbladder empyema, the pus collection?
That needs urgent 5E antibiotics and drainage. Sometimes a percutaneous cholecystostomy is done first, putting a drain into the gallbladder through the skin under imaging guidance to control the sepsis, followed by cholecystectomy later when the patient is more stable, or sometimes urgent surgery.
Drainage first, maybe. And gallstone ileus, the bowel obstruction.
That almost always requires surgery, usually a laparotomy, an open operation, to find the stone in the bowel and remove it through a small cut in the intestine, an enterotomy. The key is to remove the obstruction. Dealing with the gallbladder fistula might happen then or later.
Okay, surgery for gallstone ileus. What about preventing stones in the first place or stopping them coming back? Any prophylactic measures?
Well, for people with known asymptomatic stones, as we said, it's usually watchful waiting. Prophylactic cholecystectomy isn't routinely done just because stones are present without symptoms, unless maybe in very specific high-risk groups like transplant candidates or those with sickle cell disease, perhaps.
So generally, no preventative surgery.
Not usually. UDCA medication is sometimes used prophylactically in situations known to carry a very high risk of stone formation, like during rapid weight loss after bariatric surgery.
UDCA for prevention in specific cases.
Yeah, and generally maintaining a healthy weight, balanced diet, regular exercise. The usual healthy lifestyle advice is sensible, though the direct evidence for it preventing gallstones, specifically in the general population, is a bit limited. It's more about reducing risk factors like obesity.
Okay. Now, surgery sounds effective, but are there risks with cholecystectomy?
All surgery has risks. With LabChol, the most serious specific risk is injury to the bile duct, which happens in maybe 0.2%, so quite rare, but can be serious.
Bile duct injury. Okay.
Some people experience temporary issues digesting fats afterwards, needing a low-fat diet for a while. That usually settles. And a small number get post-cholecystectomy syndrome, ongoing pain or digestive symptoms, which can be tricky to manage.
Post-cholecystectomy syndrome. Rare, but happens.
Yes. And ERCP, which we mentioned for duck stones, also has its own risks: bleeding, perforation, causing pancreatitis, or worsening cholangitis. So it's not undertaken lightly.
Risks with ERCP, too. Got it.
Mm.
What about things like laser lithotripsy? Is that used?
It's an option, mentioned in NICE's guidance, for breaking up very difficult bile duct stones that can't be removed by standard ERCP techniques. But it's quite specialized, and long-term data is still a bit limited.
Specialized technique. Okay. So overall, what's the prognosis like for someone diagnosed with gallstones?
Generally, it's good, especially with appropriate management. Asymptomatic stones often cause no trouble throughout life.
Stay benign.
Yeah. And for symptomatic stones, cholecystectomy is very effective at relieving symptoms and preventing recurrence of colic or cholecystitis in most people. The prognosis really depends more on whether complications develop and how promptly they're treated, and any other underlying health issues the person has.
So generally favorable if managed well. Okay, let's just quickly summarize the main complications again, just to reinforce them. What are the big dangers?
Okay, key complications to remember. Acute cholecystitis inflammation, choledocholithiasis, stone in the common bile duct, gallstone pancreatitis, inflammation of the pancreas,
Right.
gallbladder, empyema pus in the gallbladder, gallbladder gangrene or perforation tissue death and rupture, gallstone ileus bowel obstruction.
Serious stuff.
Absolutely. Untreated, some of these can be life-threatening, and even just recurrent biliary colic, while not directly dangerous, can really impact quality of life significantly.
Definitely sounds like something you want to manage properly. Okay, so key takeaways from this deep dive. Gallstones are common, solid deposits, mostly cholesterol-based in the UK. Think 5 Fs for risks: fat, female, fertile, 40, family history.
Yeah, crucial mnemonic.
Presentation is often asymptomatic, but key symptoms are biliary colic, intermittent RUQ pain, often post-fatty meal, or acute cholecystitis, constant pain, fever, tenderness, positive Murphy's.
Don't forget cholangitis, Charcot's triad.
Right. RUQ pain, fever, jaundice. Investigation leans heavily on bloods, LFTs, CRP, WCC, and especially abdominal ultrasound.
Ultrasound first line. Then maybe MRCP or CT if needed.
And management. Watchful waiting if asymptomatic. Low-fat diet might help symptoms, but definitive treatment for symptomatic disease is usually laparoscopic cholecystectomy.
With ERCP playing a key role for managing common bile duct stones and complications like cholangitis.
Excellent summary. It really highlights the importance of recognizing the symptoms early and getting the right management plan in place.
Absolutely. Understanding that spectrum from asymptomatic stones right through to life-threatening complications is key.
Definitely food for thought there, particularly around lifestyle factors and recognizing those early warning signs. Well, we hope this deep dive has really solidified your understanding of gallstones.
Yeah, hope it was useful for revision.
And if you are revising and want more resources, do check out passthemsra.com and also freemsra.com.
Great resources there.
Thanks so much for tuning in and diving deep with us today.